signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in polls and live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
Good morning, good afternoon, good evening, and good night to everybody, as we say here in the SICOT family. My name is Labidi, and I'm an orthopedic consultant in Birmingham, England. I'm one of the SICOT Foot and Ankle Committee members, and today I'm quite excited to present a bunch of experts of ours that will talk about insertional Achilles tendinopathy from histology to tendon transfer. So please hop on to the journey, and I'm glad that you've joined today, whichever time of the year of the day it is, and I'm hoping that you're going to contribute with questions. Please do contribute with questions. Any comments or questions are more than welcome to be submitted in the Q&A section. So I'd like to start with our first talk. So just quickly, we have Moez Ballal, we have Arvind Puri, we have Christian Ortiz, we have Rahul Upadhyay, and we have Zongpcian Li. So I'll be giving you a brief about each one of them and what they're going to talk about just before that. So please, Moez. So Moez Ballal, so he's one of our foot and ankle consultants, and he works at Sheikh Shakhbout in Abu Dhabi, Emirat, and he is also part of the SICOT Foot and Ankle Committee. He's vice chair. And he's also a member of BOFAS, which is the British Foot and Ankle Society, as well as the European Foot and Ankle Society. Moez will be talking about histology, histopathology, examination, and assessment, and that's the most important, one of the most important things, which is the beginning and how to detect everything. On to you, Moez.
Thank you very much, Mai, for the introduction. So, this is where I work. I work in the United Arab Emirates in Abu Dhabi, in Sheikh Shakhbout Medical City. So I'm going to be talking briefly about the footprint of the Achilles tendon. So if we divide these different fibers and the fascicles of the gastrosoleus complex, we'll end up with the medial head, lateral head, and the soleus, and they are all combined, are attached to the middle facet of the calcaneal tuberosity. The calcaneal tuberosity, as we know, is composed of the superior facet, middle facet, and the inferior facet. So the superior facet has no attachment of the Achilles tendon. And if we go further into that footprint, as I mentioned, so the attachment is in the middle and in inferior third. Okay. The superior fascicle The superior facet has the pouch for the retrocalcaneal bursa, and that superior facet is lined by fibrocartilage. So the middle facet has the attachment of the soleus medially and the lateral head of the gastrocnemius laterally, while the inferior facet of the calcaneal tuberosity has the attachment of the medial head of the gastrocnemius with continuation fibers that goes all the way down into the plantar fascia. Now, there are some variations. There's some studies that shows a little bit of variations in this footprint, but the most important part is that the superior facet, which is lined by fibrocartilage, has no attachment of the Achilles tendon. So, what is the Achilles tendon made of? It's made of now 95% of type 1 collagen, which is known to be very flexible, very strong. And with age, normal aging process, we get reduction in the content of the type 1 collagen. Okay, and for that type, for those fibers to remain healthy, it needs appropriate loading, and those appropriate compressive loading are quite vital to maintain the extracellular matrix hemostasis and fibrocartilage regeneration. And those loads have to be an equilibrium between catabolic and anabolic loads. And these are in the form of stretches and compressive forces in ankle dorsiflexion. Now, if this equilibrium is disturbed or disrupted by various factors, extrinsic and intrinsic factor, then we get an increase in the catabolic activity. And what will happen, we get increased protoglycans, increased water content, and increased and disorganized type 3 collagen. So what is it tendinopathy? Is it tendinitis? Is it tendinosis? So tendinopathy is the clinical condition that we see. It's pain, swelling, impaired function of the tendon. And tendinitis is the inflammation of the tissues itself. And the tendinosis, that's the chronic condition, or the degeneration of the tendon. So what's the incidence? So the Achilles tendinopathy, as mentioned, it's a clinical syndrome of pain, swelling, and impaired function. It's got two distinct types. You've got the insertional and non-insertional. And interestingly, the insertional is less common than the non-insertional. Well, that's what the literature shows. It's up to 25% insertional tendinopathy, while it's up to 60% non-insertional. But that's not the case where I'm practicing. I'm seeing more insertional than non-insertional. It could be because of genetical variations or other external factors. That's a separate topic. And as we get older, we tend to see, or we get less athletics, we tend to see more insertional than non-insertional. And as mentioned before in my anatomical sections, we have those repeated compressive forces on the Achilles insertion from the superior fascicle, and the bigger the calcaneal tuberosity or the haglans, the more symptoms we get. And again, the more tighter the gastrosoleus complex, the more symptoms that we get. So the insertional Achilles tendinopathy is characterized by a complex of mechanical stress, vascular impairment, inflammatory response, dysregulation of the extracellular matrix, and the Achilles tendon insertion. As mentioned before, we've got excessive and abnormal loading that disrupts the repair mechanism and that equilibrium between the catabolic and the anabolic hemostasis of the Achilles. And as a result, we get loss of the strong parallel fibers of the type 1 collagen, fatty infiltration, and capillary proliferation. So I've mentioned before, we've got extrinsic factors, we've got intrinsic factors. So what are the intrinsic factors? Biomechanical abnormalities, leg length discrepancy, diabetes, cavus or foot deformities, enthesopathies, and inflammatory disorders. In extrinsic factors, poor techniques, poor footwear, changing in training patterns, environmental factors, certain drugs. If you look at the histology of the normal Achilles and the Achilles insertion in the top left, you can see there's normal fiber cartilage, and where there are inflammatory changes, you get bone destruction, you got fragmentation. And again, if you look at the fiber cartilage, you get fissures and cracks in the fiber cartilage, and you get delamination in the Achilles tendon itself. So what happens with the repetitive loading and compression? You get tenocyte apoptosis, you've got chondrocyte metaplasia, you've got production of metalloproteinase enzymes, and you get degradation of the collagen and proteoglycans. Even more, you get sprouting of nerve endings in the annural tendon, and that's what can lead to release of neural mediators, and this could be the causes of pain as well. So what are the common symptoms? Patient will come to you with pain, swelling, that is mainly over the posterior heel, and impaired function. It becomes worse when going upstairs, and with repeated activities. It's got point tenderness over that area. If it's a true insertional Achilles tendinopathy, you get tenderness or swelling around the Achilles tendon anteriorly, if that's associated with a large retrocalcaneal bursitis or a large Haglund's deformity. So what are the aggravating factors? The patient will tell you that he will have pain, especially going hill running, going upstairs, made worse by aggravated stretching. And if you dig deep in the history, you'll find that there is a recent history of increased training over the past few months, something that is not down to his routine. And the patient will complain of increased stiffness, especially after prolonged periods of rest. Examination, again, you will get painful swelling over the posterior heel. You've got positive silver scroll test indicating a tight gastrocnemius. Investigations, weight-bearing X-rays, box standard, gives us an idea about the anatomy of the calcaneum, gives an idea about the size of the Haglunds, any calcification within the Achilles tendon. Ultrasound is very useful to look for any hypervascularity. It gives a dimension to measure the Achilles thickness, the presence of retrocalcaneal bursitis. MRI scan, again, really useful to look for other unusual causes of posterior heel pain, such as stress fractures of the calcaneum. It also shows bone marrow changes at the Achilles insertion, the presence of bursitis, the presence of Achilles tears. And that's a typical picture of an MRI scan. Now, just to put in mind that up to 35% of asymptomatic patients will have signs of tendinopathy, and almost 20% of symptomatic patients will have normal imaging. So what's the management? The first line is always conservative, always reduction, more of an education to the patient about reduction of activities, the use of non-steroidal anti-inflammatory medicines, eccentric loading. Shock wave therapy has been found to reduce pain by 60% and with 80% patient satisfaction. Just put in mind that this is the list of differential diagnosis of someone coming with an insertional Achilles tendinopathy, retrocalcaneal bursitis, fat pad inflammation, Achilles rupture, paratendinosis, osteotomy, and the list goes on. So always think of those of this list when someone comes in with similar symptoms. Thank you very much.
Thank you very much, Moez. That was really very insightful, and thank you for taking us through in a very systematic way. I think it's quite important to know, from the histology going onwards. So I had just a question for you regarding, you mentioned vascularity. So you said to pay attention to the vascularity. What does that change in the diagnosis with the ultrasound? Because that's always something mentioned.
So there would be increased vascularity at the Achilles tendon insertion. There'll be rapid recruitment of inflammatory cells around the insertion, maybe weakness of the insertion, if that's what you're talking about.
So, because you mentioned it, and I know that a lot of people get confused, mainly, people who do these scans. So I think it's worthwhile mentioning that if you have some inflammation, that would probably be some tendonitis rather than tendinopathy itself. And if you have like new formed capillaries and you have a lot of activity there, turn of capillaries, then that would indicate tendinopathy. So I think that's great that you mentioned it. Okay, perfect. Thank you very much, Moez. I don't see any questions at the moment. So I think we can head on to the next talk, if that's okay with you. So we have Rahul. So Rahul is going to tell us about the reattachment and SpeedBridge, isn't it, Rahul? So just a little bit about Rahul. So Rahul is an orthopedic consultant. So he's done a fellowship in Singapore, which is quite interesting for, I believe, the rest of the world. He's done the SICOT diploma. So this is an opportunity to encourage everybody to do the SICOT diploma. And more interesting is, I would say, that you are the fellowship committee chair in India for the foot and ankle, and you're the founder, isn't it, of the foot and ankle fellowship in Jaipur, which is quite nice. And I would encourage everybody who doesn't have some sort of foot and ankle fellowship program to do that. And quite a lot of achievements, Rahul. Very well done. So you're head of the foot and ankle surgery at the Rajasthan Hospital in Jaipur. You're the executive member, you're one of us, isn't it, of the SICOT, and as well as the Indian Foot and Ankle Society. Rahul, please do take us through the reattachment and the SpeedBridge.
Thank you, Moez. Thank you so much for the generous and kind introduction. Hello, everyone, and we'll be talking about the Insertional Achilles Tendinopathy. So this is the city of Jaipur where I work, and I would welcome all of you to visit it once at least. So I'll just present a few scenarios. So this is a young female with a tendo Achilles pain, which is only on a prolonged walk, which is not on a general walk, which is not on the standing, no rest pain. Whereas we have this patient who is a 42 years old male who has an insertional pain, which is present and on normal walking and increases gradually with the walking. And then we have this large gentleman who is 28 years of male who has insertional pain plus the rest pain. Now, as Moez said in his talk, that in our side of the world, especially in India, we see insertional tendinopathy much more than non-insertional. And for us, it's more than 90% that we see insertional tendinopathies, and barely ever we see any non-insertional cases. So the idea of this is to talk about the SpeedBridge, which is very commonly used here, and I really love this procedure. So within the next few minutes, we'll just see how to proceed with this technique. What are the common techniques to do a SpeedBridge, open SpeedBridge fixation of the tendo Achilles. So for all these three patients, different kind of scenarios, different kind of X-ray presentations, we had employed the single technique. This is the SpeedBridge. We did follow the routine investigations like ultrasound and MRI. So that is not something that I'll be discussing about. So we'll just head directly to the clinical findings. So we could see the huge bumps on the posterior side of the heel. We could see the tenderness present over the insertion of the tendo Achilles. So these are the various treatment options: calcaneoplasty with the SpeedBridge, Zadek osteotomy, arthroscopic debridement, FHL transfer plus minus. We can go for a open or a percutaneous Higland bumpectomy or an FHL transfer whenever it's needed. And we here will be talking about the Higland SpeedBridge. We'll take you through a short videos of these techniques. So wherein we have employed a direct posterior approach to the tendo Achilles, and we have used the tendo Achilles a splitting technique to have to address the pathology. Now, for a SpeedBridge, either you can do a tendo Achilles midline splitting, through which you can address the Higland bump and the deformity, or you could go and elevate the entire insertion of the tendo Achilles from its original site and then access the heel in more generosity. The idea of going a tendo Achilles split technique is that you still have some amount of insertion that helps you in achieving the accurate tensioning of the tendon of Achilles. You know where exactly the footprint is. You are not moved away from it even after you have done the bumpectomy. So this is after the tendon of Achilles splitting. This patient had a lot amount of fluid which came out after we did a splitting of the tendon of Achilles tendon. And once we did that, we had a direct exposure of the large Hageland bump. And once we had that exposure of the Hageland bump, we had to have a generous removal of this large bump. So I have used an osteotomy. You can use your mini saws or any device that you choose to use. And be generous in removal of this because sometimes we think that we have overdone it. But if you see a post-op X-ray, you will see, no, actually, it was not much. The only important thing while doing is that you make sure that your direction of the osteotomy or the burr or the saw is so that you do not enter inside this posterior subtalar joint. That is very, very important. So you have to be very careful about that. Once we have done and remove the Hageland bump out of it, we can identify the site of insertion for the suture anchors that we are going to use for the Achilles SpeedBridge. So in the figure, we can see on the right side that I have marked 4 points for this insertion. And my idea is to keep at least a centimeter of distance between all the 4 points. It's kind of a square or a box that I make, wherein the external part is on the inferior part of the Achilles, or inferior part of the posterior tuberosity, wherein I do a final attachment of my suture anchors along with the fiber tapes. So if you see, we have marked 4 points here. And this is how we go. So we have to do a pre-drilling as per the suture anchors that we are using. So here we are using a 4.75 anchors with the preloaded fiber tapes. And for that, we're using a 3.4 millimeter drill bit first, followed by a tapping. Now, this is very essential step if you're using especially a prefabricated designs like Arthrex or something, which has its own toolkit. So once you have done adequate tapping, then you use a preloaded fiber tape to insert into this is the preloaded fiber tape that we are trying to insert into it. And once you have achieved, your anchor is gone inside, you take it out. Now you have a good attachment. You have a good hold inside the calcaneus of these two anchors. Now since these are preloaded tapes, you can take these tapes out from each section of the tendon Achilles on either side, on lateral or medial side. So if you see now, we have a good hold of the tendon Achilles here using these fiber tapes. And once we have done that, you can pull these both sections of the tendon Achilles and reattach it over this original insertion site. Now, this is on the inferior part of the posterior tuberosity, where we are making the next entry point or the next portal for the suture anchors. And then this is the last portal where we are pre-drilling it with a 3.4 mm drill bit, as we discussed, followed by the tapping. Sequential tapping has to be done. And once we have done that, now what we will do is we'll reattach this tendon. So using a 4.75 mm Swallow anchors. So this is in a crisscross fashion where you use one limb of each of the fiber tapes and reinsert on the other side. So you cross your tendons in a crisscross fashion that gives you a more stronger hold. And the other two fiber wires which are present in between, they give you enough freedom to suture back the incised part of the tendon Achilles. So this is what we are doing here. So this is just to suture back the incised part of the tendon Achilles. This is once we have passed the fiber wires through each of those parts, we can at the end of the fixation try to suture it back into the original position. Some people prefer to do it before they they do the final fixation of their SpeedBridge. So this is what we are trying to do. Once we have done it, I try to push it back to its normal position, or the SpeedBridge into the normal position. Now there are different ways to reattach it. Either you can use your marking techniques over the suture anchor to get the exact spot, or you can use your pull-through tension techniques to get it through. But you have to make sure that you don't lose the tension while you're trying to do that. And once you have achieved that adequate position, you have to hammer your anchor into the calcaneus into the right position. So this is, again, we are showing this right anchor to be placed into the insertion or the inferior part of the heel, and then we hammer it inside And once we have hammered it, that anchor touches the posterior tuberosity of the calcaneus or the inferior tuberosity of the calcaneus. That is where we stop. And then we use the anchoring device, which is given along with the suture anchor. So this is where we stop it. We stop hammering, and then we tighten this anchor inside. So while you are trying to tighten this anchor, it pulls your fiber tape along with that and gives you a very strong tension across. So this is what we have done. This is the final fixation that we have achieved through this. And now if you see on the right side, once we have achieved the final fixation, we can very easily try to achieve a closure of the tendoachilles or the split part of the tendoachilles using the fiber wires which we had passed through the two ends, and we can give a nice tension across it and get a good closure. So this is the final closure that we have achieved. The tendoachilles is back to its original position without changing the natural attachment. And once you have done it, usually check the tension and see for the for the plantar flexion that we are going to achieve it. So this is the post-op X-ray for the same patient. We have done an adequate removal of the Higland bump also. And this is nearly 3 months post that the patient is back to his sport-specific exercises in the rehab. Again, I would like to stress that you make sure that we are doing an adequate resection of this Higland bump, and we are not shying of removing the adequate amount. For post-op period, we have to immobilize and below knee slab for 2 weeks, followed by a walker boot ambulation and assisted physiotherapy for next 6 weeks. At the end of 8 weeks, we start a full weight bearing of these patients, and return to high impact activities is 12 to 16 weeks, depending on the patient's ability to do the supervised physiotherapy. So just a few learning points then that this open procedure, it addresses all the components of a Higland disease. The position of the anchor is vital, as I was talking about, so that we get a natural attachment of the tendoachilles back. Correct tension of the tendon has to be achieved before the final fixation. Respect soft tissue, that Moez was also talk about. That is very, very important while dissection, because it is an open procedure of the posterior calcaneus, which is notorious to go into the wound dehiscence. And the technique and the strength of this technique, it does help in early rehab and early return to the activities. Thank you.
Perfect. That was really very good. Thank you very much, Rahul. So you said that you really like these Zadek, the SpeedBridge reattachments. So are you concerned about the wound? Because I know that there are a group of colleagues who try to move away from the SpeedBridge because of the exposure and the amount of sort of compromisation of the structures around. So what are your thoughts on that?
Yeah, like I said, May, that it's a very important step, even while you're trying to expose it, that you have to respect the soft tissue. It's a known complication, but I think if we are wary of using any high stretching technique, using the pointed instruments around, trying to pull the skin away, trying to pull the tendon too much away, I think the rate of wound complication is not as high. And I fortunately have a very few complications as of now. So maybe that's the reason I'm very fond of this technique. And I hope I'll continue to do that. That's
great. And in terms of, you said, make sure that the tension is right. How would you advise people to do that? Like, do you what do you do? Do you expose the other leg as well, and then you compare, or is it just the feel, or how is it?
So so like I said, so if I'm going just for the tendon splitting technique, so that helps me a lot, because there is some attachment of my original tendon still at the ideal position. So that is very, very easy. But if you're going for complete resection of the tendon from its attachment, then I would suggest that you keep the other limb also prepared and draped over table, so that you can compare it on the other side. Also, it is very important, I always do that I see both the tendons preoperatively in the resting phase, and make sure that both the tendons have the same amount of resting tension. If they do not have, then I think the only way you can do is just feel and see this.
Perfect. Okay. Please, anybody from the panelists, feel free to ask questions as well. At the moment, we have no from the public. So thank you very much, Rahul.
Thank you.
Thank you. So now we can proceed with Christian Ortiz from Chile. So now we're going to South America, Latin America, South America. So what time is it there, Christian, in Chile? You're muted. You need to unmute yourself. So Christian is the foot and ankle surgeon. He is in Clínica Universidad de los Andes. Hopefully I said it in a correct way. What time is it?
1:30 p.m.
1:30. Okay, not too bad. So, and you're the past president of the IFAS, which is the International Federation of Foot and Ankle Societies, AO Chile chairman, and Steps to Walk Medical Board of Directors. So that is quite a great chunk. Well done. So Christian is going to talk about debridement, Zadek's osteotomy, reattachment, and FHL transfer. So our webinar is mainly as a case presentation. I missed to mention that at the beginning, so please, everybody, feel free to ask anything or discuss once the presentation is done. There you go. On to you, Christian.
Thank you, May, for that kind introduction. Are you all able to see my slides?
Yes.
Okay. So this is where I work. That's my hospital. From that little picture down there, you can now see how beautiful it is. This is what it looks like right now, wintertime here in Chile, in the middle of the ski season. So that's the university, the first buildings that you see, and back there is the same building that you see at the bottom of the slide, and of course the beautiful Andes Mountains as a background. And right now I'm in my office looking right at the Andes Mountains, very similar to this picture. So just to make something clear, I put up some cases in order for you not to get confused. If you see this young female that has this prominent bone on the lateral part of the distal Achilles tendon, do not fool yourself thinking that this is always an Achilles tendon problem. In this particular case, she had a problem because that part of the heel was rubbing against the shoe, and she had no problems of the tendon whatsoever in practicing sports or anything else. So for this particular case, in which we call this a bump problem, there's no Achilles tendon problem, but you may get confused. In this case, we just remove the prominence. Right now, I would do this with a minimally invasive saw for sure. So before you get confused, in the back part of the heel, you may have Achilles insertional tendinopathy, you may have bursitis, you may have a bump, and some people like to use the name of a Haglund's syndrome, which is very hard to define, but I would suggest, like most people like to recommend, most of the time, all these problems may come together. And that's the reason, like Rahul stated, most of the time you need to address everything with one single surgery. That's removing the posterior superior prominence of the calcaneal bone, removing part of the central problem of the Achilles tendon, reattaching the tendon, removing bursitis and everything. So most of the time you face these problems, but occasionally you may be facing a bump. Let me bring you into a different scenario, female runner, in which I decided many years ago to perform an arthroscopy. So this is what I did. It's my first one in which I decided to remove the Haglund's deformity. I was really pushing the limits. Tendon from the inside, didn't look so bad. If you pay attention, I play a lot with the burr, and you will see a very quick x-ray that looks very ugly because after 45 minutes playing around, I hadn't removed anything. So it took me about an hour and a half to remove the whole thing. And for me, it was very hard to perform, and I didn't like it so much. Then I realized that it's much easier if you use a minimally invasive burr to do this. But more important than that is that this technique, as Nick van Dijk recommended many years ago, may only be used in cases in which tendon Achilles is not severely or the other way around, is very mildly compromised. Otherwise, it's not going to work, and you need to do something similar to what Rahul just showed us. So then we have a case similar to what he showed. Actually, a friend of mine, orthopedic surgeon, of course, who had this problem for everything to extend. So we went on and did the same technique that was very nicely shown by him. In this particular case, I removed all the compromised tendon. So I ended up, not as the original technique, deattaching the whole tendon, as you can see here. So then you need to be very careful how to retension using the contralateral leg in the same. Don't forget, SpeedBridge technique is something that was invented or created or popularized by one company, but you can use this technique with any anchors. Right now, you can, at least I can find in Chile 7 companies that provide similar anchors to do the same technique. So I would strongly recommend not to call the technique itself by the name that the company uses. It's simply a reattachment technique, as was mentioned in the titles for this webinar. So I did the same thing. The only difference is that I reattached the whole tendon in the proper position, but basically the same technique that he mentioned. So we have some questions. One of it is it safe enough, and Rahul, think about this, for an 80-year-old male with vascular insufficiency, diabetes, and a wound, a previous wound in the area? Is it safe for everyone? Does it work in 100% of the cases? So let me show you one case that was not operated by me, but could have happened to me the same. It was a perfect patient to do this. It was performed by one of my friends that is actually consultant for the company that popularized this technique. He did everything correctly, but the patient didn't get better. So I tried conservative treatment for a while, then I gave up, and I decided that she needed more surgery. And I thought about it, and when you take a look at the x-ray, maybe you will be as critic as I am, and you will see that maybe not enough bone was removed from the posterior superior tuberosity of the calcaneal bone. So that's what I did. I went back in, those were the MRIs, and I removed more bone. So this is a revision of a reattachment technique. And now you can see that I removed much more. I was able to work my way around the previous holes made by the anchors. So right now, this is a good option. I like it very much, just as Rahul, but you need to consider that you may have different options in different scenarios. What if your whole proximal tendon is in poor shape? What if you had done this and then it ruptures again? Then you may have to consider, like in this male, 80 years old, chronic Achilles tendinopathy, but it's not just distal, it's also proximal. So for these cases, you can do the classical AFHL tendon transfer. We all know how to do this. Or what we prefer to do right now, when the whole muscle is gone, you just go in and perform an FHL arthroscopic tendon transfer. So you will have a tendon and a muscle doing the function of the Achilles tendon. That's me using a needle to put a suture through the FHL. Then I will cut it and I will take out the stump through one of the portals, and I will prepare that stump with some sutures. And I then, see, that's the stump, some sutures around it in high speed motion. I'm not that quick, unfortunately. Then you drill a hole as close to the Achilles tendon insertion as possible to keep the biomechanics. And for this particular case, we used a biotenodesis screw to put it in the proper position. So we're sliding in the FHL, and then we're inserting the biotenodesis screw. So it's a minimal invasive approach that in which we decide, see, the final result in the proper position, always comparing with the contralateral side. So it's minimal invasive technique. You replace the Achilles tendon when you think it is completely lost by an FHL, and you also add some vascularity because the muscle is pulled down to the rest of the Achilles tendon. So that's one reason that made us think of as a possibility to combine this option with a new one. This is something that we recently published, in which we had some doubts about the viability of the triceps surae. So we decided to do the FHL, but we also added the rest of the Achilles tendon, the proximal part, in order to preserve part of that muscle and not to give up and not use it. In this particular case, we used a biotenodesis screw and a button at the top, at the plantar aspect of the calcaneal bone to make it more stable. So when you do this, is when you have the hope. You hope that it's a wishful thinking that you can recover some muscle, and be aware that sometimes even people that are more than 1 year without using the muscle after chronic rupture, either at the insertional area or more proximal area, some people may recover the muscle. And there are several studies showing that. And we actually published that combination that I insist is the AFHL reinforcement plus adding the whatever part of the proximal Achilles tendon that you can find. And again, if you're facing an Achilles tendon problem, isolated problem of the insertional tendinopathy, do you always need to make this big incision in a patient that has a risky area of operation? In these cases, I think Zadek osteotomy is a good option. It's an easy technique that right now you can perform it this way. This is the way we do it. In this first case, we put the scope to remove part of the bump. We don't do that anymore. We just mark with our K wires. Never break the plantar cortex, as I can show you here, and remove whatever is needed. Don't bring the apex of the cut too proximal, because you may shorten the bone, the calcaneal bone, too much and end up with problems like plantar fasciitis that has been described in literature. So you need to plan carefully and remove about 1 to 2 centimeters of a dorsal wedge, keeping one bridge of about 1 centimeter plantar. Then you dorsiflex and it closes by itself, and then you add the screws. And from what I've seen, it's an excellent technique. Some people just do this, like Peter Lamb. He would never reattach the tendon like Rahul showed, he will always do this technique. The only difference that I have seen, and this is level whatever, 5, 6, or 10, is that these particular patients, they take longer to recover from the pain coming from the bone. So if I'm facing a young patient, excellent soft tissues, an athlete, I would prefer to reattach the tendon as it was shown previously. If it is someone who has risky soft tissues or risky comorbidities like diabetes, vascular insufficiencies, or things like that, I would prefer this, and they like it much more. And by the way, it is much cheaper. That is something very important. All those swivel locks and fancy anchors are way more expensive. So as a final conclusion, I can say that I like the aggressive resection of the Hacklands deformity. I like the reattachment. I love this reattachment technique, but consider Zadek for risky patient and consider FHL occasionally or as an isolated or a complementary technique for some risky patients. So like in this video, you will see that when you're facing a problem that like this fence is closing against your nice car, you can decide to do different things. Try not to choose the worst one. It may work, but it gives you some headaches sometimes. Thank you very much.
Perfect. That was a good one. Thank you very much, Christian. So I would only like to comment that with you, I don't think we will have any sponsors with all your comments. So
no, the other way around. We will get all the sponsors.
All the sponsors, okay.
At least 7 companies doing this.
Okay, we'll push you as a dummy so we can try with you and see what happens. Thank you very much. That was very insightful, and thank you for sort of showing us the reasons why should we, use this one rather than the other one, and the variety that you showed us with the videos. That was really great. Just one comment from my end is you mentioned the plantar fasciitis after following the Zadeks, and we were discussing that just before we started this. So the highlight is where exactly to do your cut, isn't it? Plantar.
If you go to proximal, you shorten the length of the calcaneal bone, and of course you're lengthening proportionally the plantar fascia. So I think that's the reason why you may end up with the plantar fasciitic problem. So that's it's actually a technical error. It's a technical mistake, I think.
Okay. I think it's worthwhile doing some studies regarding that to sort of support that for everybody too, because I think that's something that is needed. Thank you very much, Christian. Anybody has any questions for Christian? We still don't have anything from the public, so if there's no other comments, we will.
Let me make one reinforcement of what I just said.
Yes.
I think we should all question ourselves when you do one thing for everyone. It's the same thing for hallux valgus. If for hallux valgus you do Lapidos for everyone, you should question yourself. If you do minimally invasive Mica in 100%, you should question yourself. So I always trust someone who says, I've done Zadek, I've done FHL, I've done reattachment, I've done arthroscopic surgery, I've done this and this and this, and I prefer to do this. Okay, I like that person. But when someone is doing just one technique for 100% of the cases, at least we should question ourselves if we should change. And we all know the final answer. The final answer is typically that you will pick up a few cases and you will decide to do something differently. So maybe Rahul right now would do this in 98% of these cases, and I fully agree with that. But maybe that's perfect if all his cases are young people with no severe comorbidities. Maybe another ones, they just receive 70-year-old people and they may move on into Zadek a little bit more than reattachment. Those are my final comments about this.
Yeah, I think that's valid, really. That's very valuable. Thank you for that. Thank you very much. Great. Thank you, Christian. So on to Arvind, our big boss. So so Arvind, first of all, welcome from Australia.
Thank you.
So Arvind has kindly stayed awake or went to sleep and woke up in the middle of the night because it's 3 a.m. in Australia in your time zone, as far as I understand. So you're the SICOT foot and ankle chair. You're doing a great job, and we always enjoy your very joyful and colorful shirts, I have to say. You are a foot and ankle consultant surgeon. You work in Carnes is in Brisbane, Australia. And currently, I believe that you are enjoying winter. So Arvind is going to talk about having some case discussions about operations, how and also when not to operate and why not to operate. Arvind, on to you.
Well, thank you very much, May. I'll share my screen. Right. Thank you very much, May, for the kind introduction. And Christian, you are such a hard act to follow. But I'll try to talk and limit myself to when we should not operate on patients who present with what is considered as an insertional Achilles tendinopathy. And as May said, I'm from Cairns, which is the doorstep to go to the Great Barrier Reef. So it is a very pretty part of the world. Perhaps not as beautiful as Christian showed us with the backdrop of Andes, but it's got its own beauty in terms of the rainforest. We all see these patients who vary in a spectrum from being mild to very severe form of insertional Achilles problems, which could include all the facets that exist in these patients of the Haglunds, the retrocalcaneal bursitis, the thickening and the degenerate tendon they get, the bony prominences, the pain, the limitation of activities. And our aim is to try and see if we can make their life better. And what we don't want is to end up making them worse. So this is one of my cases where I had done initially a open excision of Haglunds or a exhaustectomy along with tendon debridement, reattachment, and the patient promptly had an avulsion of its insertion. So my talk is going to focus on to try and avoid problems before we offer somebody any form of surgery. Now, complications that exist in literature because of the nature of the surgery we do is something we all have to learn how to address when faced with it. But to have created problems for the patient or in ourselves by doing something which could have been avoided is what I'm going to mostly try and focus on. So the first thing I want to tell is the patient should earn their surgery. So in my practice, every patient who comes with a confirmed diagnosis of insertional Achilles tendinopathy have to go through a 6 months regimented, supervised, non-surgical management, which includes eccentric exercises, injections if necessary, orthotics, pain relief, anti-inflammatory medications, and some patients do insist on getting PRPP or extracorporeal shockwave therapy. So they do have to go through at least 6 months of that treatment. And going by what has been seen anecdotally and written in the literature, a lot of them do get symptomatic relief and are able to adjust their lifelong and carry on and will not require any surgery. So how good is the non-surgical management? So eccentric exercises in literature say that you could have even up to 83% of the patients benefiting, extracorporeal shockwave therapy up to 73.7%, injection therapy using steroids or PRP up to 73%. But overall, I think most studies kind of agree that there is quite a high failure rate or dissatisfaction rate amongst this group of patients, even if they have been managed non-surgically for up to 6 months' time. So none of us want to be what this old orthopedic saying said, that every operation was necessary except the first one. So to avoid this kind of a situation, which is not at all something which is conducive for patients' improvement or for our own well-being and our results, is to make sure of a few things, and which are: you must diagnose the condition correctly. You must try and put them through non-surgical management. And then when you have decided that this patient requires surgery, make sure that they have been optimized to the best that you can, and then offer them, as Christian said, the most appropriate surgery in individual cases. Don't have one recipe for everybody, because patients vary. They come in different shapes, sizes at the spectrum of their problem, and we need to make sure that we give the patient that procedure which hopefully will benefit them best. So what does the literature say about the outcomes of surgery? So it's a pretty high complication rate in certain studies, up to 41%. There is nearly 1/4 of the patient in some studies who have a failure rate, and then a recurrence rate of up to about 14%. As shown in the previous talks, the grade B recommendation is the best that can be put forward based on level 2 and 3 studies regarding the open technique, where you go through a midline incision and lift up through the Achilles tendon, the whole insertion, at least the majority of it, do the debridement, remove the bursa, remove the bony prominence, and then reattach it back. And where you have to add on an FHL transfer, because the amount of tissue that you remove from the Achilles tendon leaves behind not enough to give them a safe function, the recommendation is even worse. It's grade C. So even though surgery is the resort that we have to turn to after having failed the non-surgical management, the results at best are just a bit better than average. So the factors that you have to take in surgical decision-making are patient factors. Their BMI, their smoking status, their diabetes, their vascular problems. You have to make sure that the diagnosis is correct, the appropriate procedure, as I mentioned, the rehab. You have to make sure that the patient you're going to offer surgery is very, very compliant in terms of rehab. Rehab is a very key component of most surgeries, and definitely in this particular scenario, it is a very, very important part. And I don't think any one of us should even forget the expectations the patients have. As has been mentioned in past talks, this is quite a common condition in patients who are keen runners and all, and they expect to go back to whatever activity they had prior to this problem. And you have to make sure that you can give them a very realistic expectation. So these are a few examples of clinical cases in which I have learned a lesson. So the first one is a colleague of mine. She's an obs and gynae surgeon in my hospital, very keen runner. She presented with heel pain, and by all clinical examinations, she appeared to have what I thought was an insertional Achilles tendon. She did have a slight posterior heel prominence at the insertion, and the X-ray didn't show us anything at all. So I started getting her to treat her with the non-surgical management, and very soon I realized that there wasn't something quite right about it. And so she had an MRI scan, which clearly showed that she did have some thickening and degeneration, but more importantly, she had a calcaneal stress fracture. So as soon as that diagnosis became evident, you had to quickly move away from what management was being offered, as if she was clinically a case of insertional, and moved on to rest and allow the stress fracture to heal. So this is really, really important. There are quite a lot of conditions that are in the vicinity of the insertion of Achilles tendon, and they can mimic, or at least make us go down the path of thinking that the problem is the insertional tendinopathy and not something else. And these are the common ones, along with having heel pad pain and other that were mentioned by Moez at the start of the talks. So this is a second example of an elderly gentleman, which, as Christian quite rightly mentioned, not everybody needs to have the same procedure. He had very typical symptoms of insertional Achilles. He had clinical radiological confirmation. I've said he underwent the routine non-surgical management, wasn't very happy, and so I thought he is a candidate for going ahead with the midline incision, trans-Achilles tendon approach, lifting off the insertion, clearing up the degenerate tissue, the bony bump, the bursa, and reattaching it back. But his wound became a really big problem. It just wouldn't heal. And finally, it dehisced. Then it dawned that maybe we should get some vascular studies done. And so the vascular opinion was that he had a poor flow in his leg with stenosis of most vessels, and then required a vascular procedure followed by plastic intervention to cover the wound. And I learned my lesson. Now, sometimes just palpating the dorsalis pedis or posterior tibial is not enough. Looking at a patient as a whole, getting a history of them being a vasculopath, they might have had heart problems, they might have had stroke in the past. Their feet might show quite clearly signs of somewhat compromised vascularity, especially as you see in diabetics. The skin color, the changes in the nail, the way the foot appears, all could give you and raise the suspicion of having a vascular issue. So it is important that if you're suspecting anything, put the patient through as many investigations as are needed to confirm that they have a good flow and not offer them surgery straight away. Smoking, we all know the downside of this. I had a 48-year-old male who both clinically and radiologically fitted into the IAT diagnosis. He was an active current smoker. He failed conservative management. I did the operation for him, and he promised me that he had given up smoking. Unfortunately, his wound took a long time to heal. Now, I'm not saying this is entirely due to smoking, but I think it played a considerable part towards it. And on questioning after that, he said he hadn't given up smoking. And so all my patients who are current smokers who promised me to give up smoking undergo a cotinine test before they are taken to theater for surgery. This is a very cheap, reliable test in which you can detect remnants of nicotine in a urine sample. So this is another lesson that I learned during my time doing these surgeries. So my basic and very straightforward, simple offer on do not offer surgery principles are: if somebody has an active skin infection, they've got a very poor soft tissue envelope, they have uncontrolled diabetes of an HbA1c more than 8, they have a very high BMI in the high obese category, or they have multiple comorbidities along with what we have mentioned before, the vascular problem, and if they are smoking. So it is really, really important that before we offer anybody any surgery, that we know the situation, conditions, patients that you do not want to offer any surgery to. So it is not unreasonable to seek help early from the dietitians, the endocrine specialists, vascular surgeons, and introduce the patient to the quit smoking program before you go and offer them surgery. Thank you very much.
Great, perfect. Thank you very much, Arvind. That was quite interesting, especially because we've been hearing about the surgeries and everything. So this is quite important to say that truly you need to be very, very careful how to select your patients, and unfortunately we have to believe the patient when they say that they stopped smoking or not, but often it's not the case that they truly have, and it does affect that. Also, from my personal experience, I would say that the post-operative infection control, which is mainly under patient's control, that's something very difficult to plan and to predict. Yeah. So I didn't know about the test. That test is quite, I wrote it down, so I'll see how can we get that. I believe you need some consent from the patient. Is that correct?
Yes, that's correct. But you have to take the patient's consent. It's a very simple test. The result is very quick to come through. And from my understanding, it is quite a reliable confirmatory way of, checking if they are still continuing to smoke.
And would that be like you do the test and you do it on the day of the surgery?
Yeah, it's like one of these COVID kind of things.
Yeah.
You can buy those off the shelf in the pharmacy, or you can get them from the hospital, and you just get the patient to do the test. And if it's positive, you just have to tell the patient that you're not going to go ahead.
Right. And from your experience, how did they react if you had that experience?
Well, I think most of them would very quietly acknowledge that they have been smoking. Some, of course, have a more aggressive attitude where they have come prepared for surgery and they want it, and it takes a bit of time to explain to them that they really can't have this done because of all the potential problems. But majority, I find, just quietly acknowledge, yes, I do, and they're happy to go away and give it another try if they want to.
Right, perfect. Anybody has any comments or questions for Arvind? All right, thank you very much, Arvind. So I think we can proceed with the final presentation, which is from Zongpcian Li. So Zongpcian is also in a early morning / night mode, I would say, from Singapore. 2 a.m. I just Googled it now, time zone, and it says 2 and 7 minutes. So thank you for staying awake or going to sleep and waking up in the middle of the night. So Zongpcian, so he works in the Singapore General Hospital as a foot and ankle surgeon. He's clinical assistant professor at the Sing Health Duke NUS Medical School and senior clinical lecturer at the NUS Yong Lu Lin School of Medicine. And so you do general orthopedic trauma, minimal invasive, arthroscopic, endoscopic, foot and ankle surgery, as well as arthroplasty. On to you, Zongpcian. You'll be telling us about debridement, Zadek, and FHL transfer, and sharing some cases.
All right, thanks, May, for the very kind introduction. Can you guys see my screen right now? All right. And so I'm just to end up the talk today, I'm just going to talk about a couple of cases of mine to discuss the variability of presentations as well as treatment options. Just to sum it up. So the first case I've got is this 35-year-old nurse that works in my hospital, presents with a duration of 6 months history of posterior heel pain. So we assessed her and found to be an insertional Achilles tendinopathy. She had a fair trial of physiotherapy, heel lifts, as well as shockwave therapy. But the symptoms are still persistent and getting in the way of her clinical work. So we opted for surgery with her. So this is her x-ray. We can see a very significant posterior heel as well as a plantar heel spur. But fortunately, she didn't have too much of a plantar fascia symptoms. So we opted to leave the plantar portion intact and just dealt with the posterior insertional tendinopathy. So I think early on in the lectures, a couple of my colleagues have alluded to the issues with Zadek as a rotational osteotomy resulting in the plantar prominence. So especially in this case, we got to be a little bit more cautious about it. But fortunately, we didn't have to do the plantar fascia and plantar spur. So we went ahead with straightforward excision and double row repair, not to call it SpeedBridge as Christian suggested. So very similar to what Rahul mentioned. A small incision directly at the back, split the tendon, lift it off. Generally, debride off the amorphous tendinopathic portions of the tendon, as that can be a source of pain generator as well. So as like what Rahul mentioned, you got to do an adequate debridement of the bursa, adequate decompression. I find it very important as well that not just should we excise the Hagland bump on the superior portion of the calcaneum, but very importantly, we got to debride the medial and lateral bump as well. Because very often we just take out the top and close it up. They still have this medial lateral prominent that they can complain of with footwear, right? So in this case, on the rightmost picture, you can see that it's sawed off nicely. So this is the intra X-ray. They are rounded off both superiorly as well as medial laterally. Thereafter, we proceed with the double row repair, like what Rahul mentioned. And I use usually the holding stitch to just tie up and oppose the split in the Achilles tendon at the center. Right, so this is the end of it. We have a nice closure, it's nice small incision, about 4 or 5 centimeters. Yes, as much as we want to conserve incision and prevent trauma, but if we have an incision that's too small, we end up pulling and stretching it a lot. So I do find this double row incision much more conservative compared to if you do a traditional 2-anchor Kessler repair kind of, or this whip stitch Krakow repair kind of method. Right, so this is the pre and post X-rays. You can see that the bump and the enthesiopathy, calcific enthesiopathy excised, as well as the faint shadows of the two double row repair that we inserted for her. All right, so in my institution, we published a bit of the results in FAI of this direct central tendon splitting approach, and generally it gives quite a good outcome. Yes, people do talk about wound problems with centrally oriented position, the incisions compared to a medial laterally based one, but so far results has been quite good. So slightly different, this patient, 46-year-old, who came from the other side of the planet, working as an IT worker in Singapore, tendon Achilles as well as plantar fascia pain for 5 years. So if you look at his X-ray, it is very impressive. This Haglund's as well as this calcification of both the posterior as well as the plantar fascia. So he had very significant symptoms on both sides. So this is also another one of those red flag patients that we shouldn't be doing a Zadek, right? Because correcting one will definitely exacerbate the other symptom. So in this case, we opted for 2 procedures. So one would be the open Haglund's excision. I felt that his Haglund is a little bit too impressive to do an arthroscopic debridement or MIS burring. At the same time, we did an endoscopic plantar fascia debridement and release. So you can see the pre and post, the posterior Haglund has been smoothed down. We managed to take out a little bit of the plantar calcification, but a big part of it was especially the calcification within the plantar fascia had to be left alone. But he did have significant improvement of symptoms after surgery. So the third case that we talked about, moving on a little bit to other options of treatment for insertional tendinopathy. So this patient, a 58-year-old cleaner, she doesn't have the best control of diabetes with 8.7. So this belongs to a little bit of the no-go zone that what Arvind mentioned earlier on. But she did have very significant pain to the extent that she couldn't proceed with or continue with her job, and she had to leave her previous employment. So she came in with this poor HbA1c and severe symptoms. Having failed some therapy previously, we had to think of option that would probably help her symptoms, but yet minimize the risk of complications as much as possible. So after much discussion, we decided to proceed with a Zadek procedure with her. So this is her X-rays. So if you go by Yves Tonier's paper with the XY ratios and the calcaneum pitch, she does have quite a long calcaneum, which I'll touch on a little bit later on as well. So these are some of the intra X-rays. This is how I generally perform it. So I do it usually in a lateral position because I find it a little bit easier with orientation, and you don't require as many assistants. You mark it out with KYs beforehand where you think you want to do your osteotomy, and through a percutaneous hole you burr as much as you can. So I do find sometimes it's a lot easier if you dorsiflex the ankle and burr at the same time, as that will close up the gaps. So you just keep holding it in dorsiflexion and run your burr in between the 2 wires, and that would usually burr off the asperites or the irregularities that's preventing the closure. So eventually, as you keep burring, you see your 2 wires closing up together. So as the 2 wires meet up, then you just pass your guide wires from the back and put in your compression screws. Right, so these are post-op X-rays. Nice opposition. And these are the wounds that you have. So 3 small sub-centimeter holes with excellent healing without any wound infection or breakdown issues. So a little bit of learning point from this, because the general teaching for Zadek would be an incision over the dorsal cortex, would be an excision of at least about 8 to 10 millimeters. But I find sometimes with smallish Asian patients, this 8 to 10 millimeters may actually represent half of the calcaneum, right? So this is one of the things that we got to take note when we do such procedures as well. All right, so the last patient that I'll be talking about, similarly, insertional Achilles tendinopathy, failed conservative treatment, difficulty at work. So in her case, you can see that she has a high calcaneal pitch, which makes her an ideal candidate for doing a Zadek. But she does have this prominent plantar spur that we see. So like we were saying, she currently, before the surgery, she didn't have any plantar symptoms. But as you can expect, theoretically, mechanically, if you do a closing wedge Zadek osteotomy, you will tend to rotate the calcaneum. So in this case, it will be an anti-clockwise rotation. And if you follow that train of thought, your calcaneal spur that originally ran parallel to your plantar fascia, parallel to the floor, will end up pointing plantarly, right? So what wasn't impinging initially may end up impinging into your plantar fascia. So in such cases, either you don't do a Zadek, or at the same time, what I choose to do would be to use the MIS burr to deal with the plantar spur at the same time. So the same method, plantar flexion, dorsiflexion, burring, put in the screws, but at the end of it, you put in the MIS burr, you locate it, and you just burr off the plantar fascia a little bit just to minimize the prominence after you've derotated it. So in this fashion, not the cleanest excision of your plantar fascia, plantar spur, as compared to endoscopic excision, but we managed to round it off a little bit. So post-op, she didn't have too much symptoms from her plantar fascia. She was quite happy with the Hecklands and tendon Achilles treatment. Right, so I was intending to include the FHL transfer patient as well, but unfortunately I did not really have the arthroscopic images with me. But like what Christian mentioned, I think the patient that I had in mind was this 80-plus-year-old patient. They came in with this degenerative rupture of tendon Achilles. So we listed her for repair. But unfortunately, a week before her surgery, she developed a heart attack. Hospitalized. She survived it and she saw me after that. But the cardiologist's recommendation to hold off any form of non-urgent surgery for the next 1 year. So she actually limped on torn tendon Achilles for the whole year before coming back to see me. So like we mentioned, we want to do a minimal invasive, low bleeding, low quick surgery. So we did endoscopic FHL transfer without touching the Achilles tendon at all. And she did amazingly well. At about 6 weeks, 3 months, she was tiptoeing, walking very happily. The wound had no issues, and she claims that the FHL side was actually stronger than her non-torn side. So I don't know whether thinking along these lines, we can start using a primarily FHL arthroscopic transfer, isolated FHL transfer for degenerative or severely tendinopathic elderly patients with low functional demand. Just some food for thought. All right, thank you very much.
Thank you very much, Zongpcian. That was quite interesting, and I think the quite interesting fact that you mentioned the Asian feet are a bit smaller in your area. So that's something that probably in other parts of the world is not something that you would think of. So I think this is quite insightful. So you were mentioning the spur, the calcaneum spur, plantar in the plantar aspect. So how much do you think that affects anything in terms of symptoms and in terms of your surgery? And do you think it's useful to remove it, or does it make a difference at all?
So I think in patients with pre-existing tendon Achilles as well as plantar fascia symptoms, I'll be a little bit wary to offer a Zadek, definitely, because you don't want, like you said, we will end up lengthening and tightening the plantar fascia. But the ones that I still do with Zadek, then I would think about offering this MIS quick 5-minute procedure just as a prophylaxis, right? Because as opposed to doing a full-on endoscopic plantar fascia release and calcanoplasty, so that would add on a big amount of surgery compared to this prophylactic symptom. So far, in my experience, the ones that I do burr it down, and generally I try to, they don't really come back with symptoms of plantar fascia. but probably, like you said, whether it's excessive or not. Because in the end, even with that little bit of rotation, it doesn't actually change that much of the angulation. So for all we know, even if I left it alone, she wouldn't have too much symptoms. If, like you mentioned earlier on, we chose the apex and the cut adequately, so that we position the plantar apex a bit more posteriorly, so you don't end up rotating the plantar spur as much.
Okay, brilliant. Thank you very much, Zongpcian. Anybody has any comments or questions or add-ons?
So maybe a quick comment. Sorry, quick comment. Just to give you something else to think about, when would you consider a Baruch Achilles tendon lengthening procedure as an isolated treatment for this problem, or maybe a complementary procedure to everyone that we have described? Just to give you something to think. I don't want an answer, just want you to think.
Great. So I would just like to win some of Christian's trust here. So I just want to add that I do the procedures, and I'm a big fan of endoscopic FHL transfer. But just a question. So if you have a patient who is fit for all the three procedures, a ZX, an endoscopic transfer, and an open reattachment. I would not call it SpeedBridge now. So in that case, what would be your choice, or if you have actually worked on the outcomes in each of these procedures? So we are actually working on one of those studies where we're doing comparative analysis of all the three procedures in similar kind of patients. So what is your take on that?
I have no answer for that because I have no data. So I would love to see your data. Right now, we are in the process of deciding which patients are better for each procedure. And I think that I insist, maybe the risky cases with comorbidities and soft tissue risky cases, those are the ones in which I would prefer to do a Zadek. Maybe when I do more Zadeks, because I began doing reattachments, maybe when I do more Zadeks, I may end up doing as Peter Lamb does, Zadek for everyone. But I don't know. I'm looking for more data, and I would love to see more data coming from you.
Thank you.
Could I ask amongst the panelists, the guys with more experience with Zadek, because it is an indirect approach to treating Achilles tendonitis, right? This derotation and shortening, and inevitably you end up shortening the calcaneum, right? So as a lever arm and everything, do you guys see patients with weakness in plantar flexion, or do they complain problems with stair climbing and whatnot after your Zadek use up?
Moez, I think you said you do quite a lot of Zadeks. Sorry, Christian, go ahead.
I was going to say that I haven't seen it, but it sounds like a potential problem.
I don't take more than 1 centimeter, so 8 millimeters, something like that. But I do come across, like Mike said, a couple of cases of plantar fasciitis. The posterior heel pain disappears for 4 weeks or even less than that. It's gone. But they just came point of at pain at the plantar surface. And with physio, most of them tend to
subside.
Yeah. Something happened.
So I've not done many cases. So precisely, I have done only 7 cases of Zadek till now, and all of them were like not of an extensive calcific tendonitis. I'll be very honest with you. So I don't know how this is going to help these patients who have those extensive calcific tendonitis and a large bump. But yes, with the symptomatic patients who do not show much of the insertional pathology radiologically, I have done Zadeks in that, and they've shown some good results till now.
Right. I think that's quite a good variety of all these methods, and I suppose, as Christian mentioned regarding the implants, because I appreciate that in some places the certain implants are not available. So I think we've discussed everything in terms of that you can do any of those with whatever facilities you have. Perhaps the MIS not really, but I think even that one you can do it with certain burrs. So thank you very much, everybody. It was a great session, not to mention the time of the day, since we're all in different time zones. Thank you for all of you who stayed awake, and for all of you who went out of theaters and joined this meeting. I'm sure that this is going to be extremely beneficial to the audience, and especially since it's recorded, it's going to be available online for everybody. So I encourage everybody to use it for future reference and for any assistance. The QR code for the survey was just shown, and I'm just going to share with you guys the conclusions. Excuse me. The conclusions. So I think there were some overlaps. So just concluded that we need to do our investigations properly. And I believe that's something that is valid for every pathology. But we'll speak about this one in specific: insertional Achilles tendinopathy and differential diagnosis. As we saw, Moez, he gave us quite a lengthy list, which was quite useful. The insertional tendinitis is not that common. Again, as Rahul and Moez shared, that it is common where they work. However, in the literature, we do understand that it's mainly the mid-substance Achilles tendinitis. Choose a type of procedure. I think we did. Everybody repeated that. So as Arvind said, don't have one remedy for everyone, one operation for everybody. Reattachment rather than SpeedBridge. Christian, thank you for that. So definitely, I believe that we knew it somewhere in our heads, but you need to say it out loud for us to sort of, see it. So thank you. Zadek, surgery to be considered. Again, I believe not everybody has experience. I myself, I have only very little experience with that. But whoever does it, the cut and the angle and all those points are quite important. And then conservative management is to be considered, as Arvind did share with us, especially with some risky patients with many comorbidities, and the ones that we don't want to touch, isn't it? So we all have those. Thank you very much, guys, and we will see each other, and I'm inviting as much people as possible across the globe to join us at the SICOT conference in Madrid this year. It's from the 3rd to the 5th of September, so it's only behind the corner, so a couple of weeks, and we will all be in Madrid. Thank you very much.
Thank you. Thank you, May. Thank you very much.
Take care. Thank you.
Thank you, guys.
Thank you.
Pleasure.
Bye.